Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for premeds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
The first thing before we get into any cases, this is just a diagram from the American College of Physicians that talks about the pathways within internal medicine. And I think this is a good representation of all the different career pathways that you can have within internal medicine. So to start out, internal medicine training is 3 years, and that's a general internal medicine residency. And so once you complete that, you have the option of going into primary care and being someone's PCP. You have the option of specifically focusing on hospital medicine and being a hospitalist, or you can have some combined version of the two, where you do some inpatient, you do some outpatient, but you're a general internist. You're taking care of anywhere from like all the patients in the hospital, because everyone who's non-surgical is basically admitted to a medicine service. Or you are taking care of, a variety of 18 to 93-year-olds. So there's a lot of opportunity in the general internal medicine space. But if you choose to subspecialize, which a lot of people do, you have all of these. Can you see my mouse? Okay. You have all of these career pathways open to you as well. And so yes, the basic internal medicine training is 3 years, and you come out of that as a full-fledged physician, able to practice. But for a lot of people, the training ends up being 4 to 7 years, if not more. You can see that there's a lot more even within cardiology, and so the training can be long. But these are the different options that you can have, and I think that the great thing about this is, internal medicine can cater from any type of personality. So you can go into internal medicine training and realize you really, really, really like procedures, and you really, really like sort of the things about surgery that you thought you didn't like maybe going in. And then if you want to do that, you can become an interventional cardiologist, or you can become a gastroenterologist, and you basically spend your entire day doing procedures. If you decide, I really like being a master diagnostician instead, you can become a rheumatologist, you can become an ID physician. So there's something for everybody, I think. And there's, again, no two careers are alike, and there's infinite options open to you if you go into internal medicine. So I think this was the great thing about where I did residency. And in general, like, you're exposed to all of these different things within internal medicine. Like, as a medicine resident, you will admit your acute leukemia patient, but you'll also admit your, your classic ST elevation MI STEMI patient. And so you'll see a lot of different things, and you'll see what kind of medicine you're most drawn to and what kind of pace of life you're most drawn to. But the other thing is, especially a lot of larger academic centers have subspecialty services. So where I did residency, we had like an ID service, we had a pulmonary service, we had a liver service, we had a cardiology service. And so we spend time rotating through all of those different specialties. We spend at least 2 weeks on each specialty. And you're learning from a cardiologist, you're learning from a liver specialist, you're learning from attendings who have chosen to do fellowship in that field. And so that gives you a good sense of the inpatient side of it. And then you always have the opportunity to go to outpatient clinic. And a lot of internal medicine, which is not true of residency, a lot, like 75% of internal medicine is actually practiced in the outpatient setting. So that's another really good way to see what kinds of pathophysiologies and pathologies and kinds of patients you're most interested in. So the point of your internal medicine training is, yes, to give you a good foundation for general internal medicine, but also to help you see all of these different things and decide if any of them are right for you and which of them it would be. Yeah. So anyway, it can be very long. I guess the longest thing would be if you did 3 years of medicine plus 3 years of cardiology plus like a 2-year fellowship, it can end up being 8 to 9 years. But worth it. Again, it's not about the end, it's about the journey. So with that, I'm going to present two different cases. And I think some of you'll see a lot of this is about diagnosis, because I think the internist is sort of the master diagnostician. And then we'll talk a little bit about the treatment principles and we'll talk a little bit about the treatment principles. Okay, so case number one is the one-liner is a 70-year-old woman who presents with pain in her left groin, thigh, and back, and she's found to have extensive ecchymoses, so bruises all over her body. So the pain started in her left groin, thigh, and back yesterday. I actually thought it was because she was sitting too long. And then the bruising, she has, the bruising is mostly on her arm, and she 4 days ago was lifting a heavy mattress. She took some Advil and then just noticed this like acute onset of sudden bruising. So it's all kind of been in the last week that she's noticed these symptoms. So no family history of bleeding disorders, clotting issues. Something else you might want to know about is family history of cancers or autoimmune diseases. And so no, she has no family history of any of that she's aware of. She has hypothyroidism. The only medication change that she can think of is that in December, so this is 4 months later, in December she had a sinus infection, and so she took a course of amoxicillin. That's it. And then the other thing you want to think about is, depending on where these ecchymoses are, I had mentioned that she's been noticing bruising in her arm, but if you're truly concerned about extensive bleeding, and the pain doesn't necessarily correlate with the ecchymosis in this case, but you would want to make sure she doesn't have something called compartment syndrome, which is basically a significant increase in the pressure of a particular compartment in like the lower extremity or the upper extremity. And so the things you want to look for there are, does she have paresthesias? Does she have paleness to that area? Does she have good pulses? Is she having pain sort of out of proportion to exam? And if there's a really tense looking extremity, that's someone that's considered a surgical emergency. So that's something that I'd want to look for as well. Okay, so her physical exam, she has generally reassuring vital signs. She has a stable blood pressure, heart rate 69. She overall pleasant, no acute distress, well appearing. She did not have pale conjunctivae. Her heart was regular rate and rhythm. Her lungs were clear to auscultation bilaterally. Her abdomen was soft. She had no hepatosplenomegaly. And then musculoskeletally, it was really her right arm that had the extensive ecchymosis, which was purple and green from the wrist to the elbow. And that's the arm that she had said she had hurt while lifting a mattress. Luckily, that arm had soft, strong pulses, and she had intact movement of her fingers bilaterally. Her left upper extremity looked fine. And remember, she's coming in with left groin and back pain. And really, you can't see any swelling or effusions or ecchymoses of the lower extremities. She has good pulses, but she does have this tenderness to palpation along her left back. And so because she had significant concern for bleeding in her arm, there was concern that could we be missing a hematoma in her lower extremity that could be causing her pain, or what else could be going on. And so she actually in the emergency room got a CT abdomen and pelvis without contrast, and it showed that there was a 9 by 5 by 12 centimeter intramuscular hematoma involving the left iliacus, and then to a lesser degree the left psoas, with a small amount of retroperitoneal hematoma as well. So she's got a big bleed essentially in the muscles of her left lower extremity, in addition to the ecchymosis that's also going on in her right arm. So the next thing, we always think in internal medicine about how to sort of represent a patient. What is their problem representation or their one liner? And what you want to know sort of is who the patient is, what's their temporal pattern of illness? Is this something acute, subacute, chronic? And then sort of what is the clinical syndrome that you're dealing with? And this is going to help you form a differential diagnosis as to what is going on exactly, and then figure out how to best treat them. Okay, so that's a little long-winded. So just to put it together to try to come up with how you think about this patient. So she's a woman who I agree, she's 70 years old. She's relatively healthy. She's not chronically ill. This is subacute, so it hasn't happened in the last day, but it's sort of been going on over the last few days to a week. And really, like the thing that ties both of these together is that she's got the ecchymoses, which means she's bleeding, and
Hmm.
she's got a this large spontaneous intramuscular hematoma without any kind of trauma. And so something is going on that's causing her to have an increase in bleeding tendencies. And so, what are you thinking about in this patient? What kind of disorders at this point? Great. So let's talk about figuring out how you approach a patient with a bleeding disorder. So some of the things that you want to know are: is this a new or an old thing? So she's 70 years old. You asked a little bit about her past medical history. So with women, I would want to ask about their pregnancy history as well. So if they've had any deliveries, like were they complicated by postpartum hemorrhage, or were they complicated by clots, things like that. So even if she didn't specifically identify that she had a disorder, you can get a sense of whether this is new or old by figuring out by asking some of those questions. So
Right.
she's never had any problems with the dentist. She's never had any problems with her pregnancies. Her periods have always been normal. They stopped when she had menopause, and she's never had any bleeding during any procedures that she's had. Because that can cause you to have acquired bleeding disorders, particularly for someone who's never had a problem before. Family history, you guys asked about, which is great. And then medication use. So I agree. You want to ask about antiplatelets. You want to ask about anticoagulants. You want to ask about NSAIDs because that can increase your bleeding. And then the other thing you want to ask about is herbal supplements, because there's a lot of over-the-counter stuff that can increase your bleeding risk, actually. So those are things that I'd want to ask about. And then, so we sort of asked about them. So this is new for her. She has no predisposing conditions that we know about. Her family history is non-contributory, and she's not on any medications that would contribute. So let's break this down. So I think probably the two most important labs is going to be your CBC. And so you want to know, obviously, if she's having hemodynamically significant bleeding, if she needs a transfusion and things like that. But the major concern, or the major thing you want to know of how it's contributing to her ability to bleed or clot, is going to be her platelets. And then the other thing, as you mentioned, is her PTT and her INR, so her clotting factors. You want to see how those are doing. And so with platelets, you can have either low platelets or you can have dysfunctional platelets. If you have malignancy, you can have, especially hematologic malignancies, you can have things that infiltrate your bone marrow and affect your ability to produce platelets. If you are on different medications, like you guys asked about, those can sometimes cause thrombocytopenia. So those are issues. And then if you have splenomegaly from liver disease, that can also consume your platelets. And so that's another reason for low platelets. And then the other option is dysfunctional platelets, like we just talked about. So really it's the kidney disease. So end-stage renal disease can cause dysfunctional platelets. Medications, if you have myeloproliferative disorders that are going to affect your actual platelet function, some things called von Willebrand's disease. So these are really the two things you're looking for on your CBC. If you have low platelets, that's an obvious answer, and you have to start thinking about one of those things. But if you have normal platelets and everything else is normal in your factors, then you want to start thinking about analyzing platelet function. And there's different assays that you can do to analyze platelet function. But they're expensive, they're not easily accessible. And so you don't want to just jump to this right away. Like you can't order every test for every patient. And I think that's part of being a good internist too, to be parsimonious about your testing and know how to order the right tests. So that's platelets. And then the clotting cascade. So if we think about your PTT and your PT, there's different factors that make up the clotting cascade, and they're produced by the liver. And so you're not really going to have dysfunction the way that you do of your platelets, but you can have deficiencies in some of the clotting factors. So the ones that make up your PT, which is factor 7, or your PTT, which is your intrinsic factor, which is 12, 11, 9, and 8. The way that this might manifest is you might see an elevation in your INR, which is your PT, or you might see an elevation in your PTT. And so if you see some of those, then you might be concerned that you have either a deficiency or an inhibitor or something that's affecting the actual amount of the factor that's present. If you have problems with both, that is more rare, but the things that you should be thinking about are DIC, which is measured by your fibrinogen, like you mentioned, and liver failure, which is where the clotting factors are produced. So if you have issues with both, then you're thinking about liver dysfunction. So let me give you her labs. So these are her labs, and we can just walk through them. So this is her BMP, her basic metabolic panel. And so the main thing that this tells me is that her kidney function, her creatinine is 1, and her BUN is 19. And so I'm not concerned about uremic platelets like we were talking about. This is her liver panel, her LFTs, and they're all normal. And so I'm less concerned about acute liver disease being a problem. And then this is the money right here. So this is her CBC, and this is her coagulation factors, or the assays that measure her coagulation factors. And so her CBC shows a white count of 9.4, a hemoglobin of 11.3. So that's a little bit low, but it's not down to like 7 or 6. It's not super concerning. And then her platelet count is 353, which is normal. And so I know that this is not a problem with low platelets that's causing her bleeding issues. And then the next thing I want to look at is her coags. And so her INR is 1, which is normal. So I know that the extrinsic pathway is not affected. And her PTT is 47.5, which is elevated. And so now I'm thinking, okay, so I know from a platelet standpoint, I know I don't have low platelets. From a coagulation factor standpoint, I know that there's probably a problem with this side of the pathway. So we'll get into the coagulation cascade in a second, but this is your intrinsic pathway, and so that's where I'm going to focus the rest of my diagnosis. And then the fibrinogen, the way that this helps is it helps you rule out something called DIC, which is disseminated intravascular coagulopathy, and this is a normal fibrinogen level. So we know that we don't have that. So we're basically left as a prolonged PGT as the main abnormality that we're going to hone in on. And so this is your extrinsic pathway. This is what the PT measures. And this is your PTT, that's your intrinsic pathway. And so we know that her PTT is elevated. And so we have a problem along this pathway right here, or down this common pathway. And so the next step to think about is, how do we evaluate someone with a prolonged PTT? And so the two things that can cause a prolonged PTT is whether you have a deficiency in one of these factors, or whether you have an inhibitor to one of these factors. So something that's blocking the production, or something that's eating it up, basically, or preventing it from being useful. And so the way to evaluate that is you do something called a mixing study. And what a mixing study is essentially you mix the patient's blood with normal blood, and you want to see if, when you measure the clotting time, so the PTT, does it correct or does it not correct? If it corrects, that suggests that your patient's blood had a deficiency in that clotting factor. You gave it some normal blood and it improved. So that means that you were able to correct that deficiency. But if it doesn't correct, then what it suggests is that there's something in the platelets, something in the patient's blood that is consuming these coagulation factors from the normal blood that you gave it. And so it's preventing them from being functional. So that would suggest that there's an inhibitor.
Right.
So So this is how you differentiate between the deficiency and the inhibitor. And so this is sort of what I just said. Basically, if the mixing study corrects, then it's a deficiency. If it doesn't correct, then it suggests the presence of an inhibitor. So um, for this patient, we did a mixing study. It didn't correct. So that suggests that there is not just a deficiency, rather, in fact, there's an inhibitor. And so lupus anticoagulant is something that can cause an inhibitor, basically, and that testing was done and it was negative. And then there's actually something called an inhibitor assay that you can run. And again, these are all very specialized hematology tests, so you can't just order them for everyone. Like, you need to know what to order and when to order it. So this is we're down like a long pathway at this point. These aren't just routine tests that you order. And so the inhibitor assay is just serial dilutions of the patient's plasma that's incubated with normal plasma. And basically, if the inhibitor is stronger, it'll require more dilution. So hers was high, suggesting that there was an inhibitor. And then you want to know which factor is the problem. And so we're thinking about 12, we're thinking about 11, we're thinking about 9 and 10. And so her 11 was normal, her 9 was normal, and her 8 was low. And so you might think, sure, there's a deficiency, but when you combine it with the mixing study and the inhibitor, you know that it's actually not that there's a deficiency, but rather that there's an inhibitor. And so at this point, we have our diagnosis, which is an acquired factor VIII inhibitor, which is a pretty rare disorder. But you got to it by really just thinking about your normal blood tests, and then how that thing. So you get your routine labs and thinking about then, okay, what are the next steps to order based on what I already know. And so just to talk a little bit about the diagnosis, an acquired factor VIII inhibitor is a rare disorder. It occurs in about 1.5 million people per year, but it can actually be really serious. So patients can have mortality rates from 7 to 22%. Because of severe bleeding. And the majority of this bleeding is going to be spontaneous deep muscle or retroperitoneal bleeding. The reasons that this happen, for the majority of people, we don't find a reason and it's idiopathic. But for other patients, we need to always look for, is there underlying malignancy that's triggering this? Is there underlying autoimmune disease that's triggering this? Pregnancy, infection, medication changes, dermatologic issues, and then I don't actually know what this other is. And so you want to make sure, so like for her, we diagnose this, we make sure we send an ANA and a rheumatoid factor to rule out the most common autoimmune diseases. We made sure we did a pan scan on her, CT chest, abdomen, and pelvis to make sure there was no overt underlying malignancy. And then, at this point, you have to get hematology involved because this is a pretty serious disorder. And their thought was actually the amoxicillin can cause an acquired factor VIII inhibitor in some cases. And so their thought was maybe that was part of the reason. Because if you remember in her history, she has been having some hematuria as well for the last couple of months. And so, it's probably a little bit longer standing than we are aware of at this point. And so then to think about the treatment, the primary thing that's the most important thing is bleeding control. And so there's different hematologic agents that you can give to try to achieve hemostasis that actually bypass the factor VIII pathway to try to get you to clot. The second thing you want to think about is how to eradicate that inhibitor, so how to get rid of it. And you can do this with different chemotherapeutics and steroids. So she got steroids, and then she was ultimately started on cyclophosphamide, which is a chemotherapy. And then number 3 is treatment of any underlying causative disease. So that's why we look for these things to see, is there an autoimmune disease we need to treat, or is there a malignancy that we need to treat? And from what I know, she's now doing well, and she's a success story.